I'm Amal Abu-Hamdan, and this is Asayas Negrete, and we're chairing this pediatric neurosurgery session today. And we'd like to start the session by introducing Dr. Tom Merchant to speak to us on proton beam radiotherapy in craniopharyngioma. Welcome, Tom.
Here we go. I'd like to thank the organizers for the invitation today to come to this wonderful conference and represent my department and institution. I'm going to speak today about proton beam radiotherapy in craniopharyngioma. And as I speak about it, it's really about the contemporary management of craniopharyngioma. And because I'm a radiation oncologist and you're neurosurgeons, this will require a few definitions and then a short story about how we got to where we are today. So if you ask me what contemporary management using proton beam therapy would look like, this involves limited surgery, proton beam radiotherapy using image guidance, 28 to 30 fractions of radiotherapy to a total dose of up to 45 gray, a 3 to 5 millimeter clinical target volume margin, scenario-based treatment planning, and weekly MR imaging for these tumors are prone to change in size and shape during treatment. And it's also important to know that the timing of radiotherapy is really post-operative, but without urgency. There's no 30-day rule to start treatment on these patients. Age restrictions, at least at our institution, we have no lower limits. The contemporary management of craniopharyngioma with proton beam therapy also includes using that modality for patients who undergo radical surgery who then suffer recurrence. These patients can be treated with the same parameters of image guidance, 30 fractions of radiotherapy, small clinical target volume margins, and the same software. And this is the patient who's diagnosed with the incidental craniopharyngioma, who we typically observe, and if they don't have symptoms or visual pathway compromise, go on to receive radiotherapy. But for the other patients, limited surgery is the nasal transsphenoidal approach, Ommaya reservoir placement or endoscopic decompression. Sometimes patients require craniotomy, and we also include those in our limited surgery cohort. But patients who undergo extensive dissection or attempted gross total resection or even gross total resection itself, that's probably more in the radical surgery category. Scenario-based treatment planning, these are software algorithms that take into account positional uncertainty of the patient and range uncertainty in the radiation beams. And these are new software systems that are part of all new treatment planning. And basically, we plan all possible scenarios for the patient, at least their positioning during treatment, to ensure coverage of the target volume. Image guidance is as critical in radiotherapy as it is in surgery, and of course, modern equipment that's used to deliver external beam radiation therapy has all the image guidance possibilities you can imagine with image registration to ensure that we cover the target. Imaging during treatment is very important for patients with craniopharyngioma treated with very small clinical target volume margins. We often do weekly MR imaging without contrast, sometimes with contrast, and we adapt the plan. So this is called adaptive radiotherapy, where we see a change in the size and shape of the tumor. We recontour the target, adjust the treatment, and start a new plan the next day. What is the provenance of the total dose and fractionation used in radiotherapy? Why do we do 6 weeks of treatment, 30 fractions? It's really based on the Royal Marsden experience from the late 1950s and early 1960s, where patients would have their cystic tumors drained and would receive fractionated radiotherapy, and the long-term results have been published many years ago that show a disease control benchmark, progression-free survival of about 80% when measured at 10 years. Why is overall survival lower, especially at longer time points? So these are due to complications due to radiation therapy, but also patients who have untreated endocrinopathies. On the left side of the slide, you see intensity modulated photon therapy, and on the right side of the slide, intensity modulated proton therapy. Both of these modalities conform the highest dose to the volume at risk. The difference is there's a dose cloud for the intensity modulated photon therapy and the collateral low dose irradiation to normal tissues. This isn't necessarily a bad thing, but this is something we like to limit in patients who are going to live a long time, to reduce the risk of some severe or even unusual complications. At St. Jude, over the past 25 years, we've conducted 3 prospective clinical trials. The first one was called RT1, and that included patients treated with photon radiotherapy using a fairly large margin. The second trial, RT2, was first-generation proton therapy, and RT3 is the most recently completed trial at St. Jude using intensity modulated proton therapy. It's the trial in the middle that we're going to talk about in a minute. Back 25 years ago, we did everything we could to make the target volumes small for treatment and monitor them during treatment. We used special collimators on the treatment machines. We used radio camera guidance. But our clinical target volume margins were quite large back then because this was the first generation of treatment to use conformal radiation therapy, and we wanted to ensure that we could reduce the targeted volume without impacting the rate or pattern of failure. And so we also recognized the importance of MR imaging during treatment, and so in our initial study we had weeks 2 or 3 and week 5 imaging studies, and we were really surprised to see changes in the targets that we know we have to conform to ensure our coverage of our target. We published our early results showing the expected high rate of tumor control in the 80% range, and this is of the photon cohort. But more importantly, we were able to show that the dose to normal tissues can impact such things as cognitive outcomes. And so this is what really drove successive trials to further reduce the target volume margins, but also use new modalities such as proton therapy. Just last year in 2022, we reported our long-term results using our first-generation conformal therapy using photons to show that we did achieve that 80% progression-free survival and high rate of overall survival, 96%, with a minimum 10-year follow-up in this cohort. And this turns out to be a very good group to compare more modern trials using proton therapy. But with the photon cohort, we see a very low incidence of CNS necrosis. This is breakdown of normal brain tissue that usually occurs in patients who are susceptible, those who have stroke during surgery or some type of injury that precedes radiotherapy. We also looked at neurologic complications, about 13% in a supratentorial tumor. That could be expected. Permanent neurologic conditions such as dystonia, basal ganglia syndrome, and other features that we see, 6% rate with 10-year cumulative incidence. But more importantly, second incidence of any secondary tumor, about 2% at 10 years, and 1% risk at 10 years of a malignant brain tumor. And this is important because often when a patient's seen by a neurosurgeon, they'll sometimes try to talk the patient out of radiotherapy, saying, well, we don't want you to develop another type of brain tumor, but the incidence truly is quite low. Vasculopathy is a complication after radiotherapy that we're always concerned about. The abnormal cerebral angiogram, cumulative incidence about 9% at 10 years. This does differ by gender, but the rate of revascularization surgery is quite low in the 3% range, and this is a trial cohort that included over 100 patients. Ophthalmologic outcomes are quite good with radiotherapy, and as you can imagine, some of these patients are young when we initially test them, and we check their visual fields by confrontation, and then when they move on to automated testing, we find out that they have a deficit. So there's probably an overestimation of visual field changes that we see after radiotherapy in these patients. We've also seen long-term that the dose to normal tissue matters, and there are other parameters, including demographics of the patient, their age, dose to normal tissues, and shunt status. Patients who require VP shunt, at least in the older series, start out with much lower cognitive scores at baseline. So there are big differences between proton and photon therapy. You can see on the right-hand side of the slide, the photon beam goes through the patient. In order to irradiate the tumor, there's a tremendous amount of collateral normal tissue that's subtended by the irradiated volume. Proton beam therapy can be prescribed at a depth in tissue. It goes in and it stops, and this has obvious advantages for the child. Many folks modeled the potential benefit of proton therapy using photon data. You can see on the left side of the slide from the MD Anderson group some of their early modeling studies. We took our own long-term cognitive scores on the right-hand side of the slide and showed how we could better preserve cognitive outcomes in children if they were treated with proton therapy, largely reducing the collateral radiation to normal tissues. So if you're going to compare a new modality such as proton therapy to an older modality such as photon therapy, what are the three important questions? Well, first, the physical dose is the same, so we hope that the rate of tumor control is the same, and by that we would measure progression-free and overall survival. The volume that receives the highest dose is the same. Are the severe complications better or worse? Proton therapy is different than photon therapy in terms of linear energy transfer, and there was initially some concern about that difference. But looking at necrosis, vasculopathy, neurologic deficits, and vision, as we have in the photon cohort in the past, here's a good way we can compare. And then finally, the volume receives collateral radiation is less in the proton patient. Are cognitive effects lessened? So we can look at cognitive test scores. So we launched a clinical trial back in 2011 and did this jointly with the University of Florida. We treated 94 patients with first-generation proton therapy and followed those patients at St. Jude for a minimum of 5 years and just reported the results earlier this year. And what we found is that the 5-year progression-free survival is not different comparing photon and proton. We did not expect it to be. Excellent 5-year overall survival. We found that the incidence of necrosis, so this is a severe complication, is the same comparing photon and proton therapy. We found that the rate of vasculopathy was very similar comparing the two modalities, not surprising. We looked at permanent neurologic conditions. Again, 94 patients versus a cohort of just over 100, very similar outcomes. And visual deficits were similar comparing photon and proton patients. Most importantly, when we looked at cognitive outcomes comparing these two groups, we saw there was an improvement in IQ and in adaptive behavior. Adaptive behavior is a parental measure of behavior. And we saw that the proton patients were largely unchanged over time. Photon patients had a greater rate of decline. And this is statistically significant. But the important thing to look here is the y-axis scale, is that even for the photon patients after 5 years, they're still within the range of normal in terms of IQ and behavior. But this did show the potential benefit of sparing normal tissues and collateral radiation using proton beams. We've now moved on to intensity modulated proton therapy and using uniquely scenario-based treatment planning, and recently completed a trial enrollment this past summer of 160 patients and are about to look at the outcomes for those children. Key research questions for patients treated using proton beam therapy is what is the impact of surgery or surgical approach. We do have some preliminary findings. We look at body mass index is increased in patients who have more aggressive surgery. There are behavioral problems are reduced in patients who are treated with transsphenoidal approach, and it's probably something you might expect. However, we do see sleep disorders in patients who have diabetes insipidus, and that is not a typical radiation-related side effect. It's uniquely something that we see at presentation or after more radical surgery. So in summary, proton beam radiotherapy results in high rate of tumor control, a low risk of severe complications. Its advantage has been demonstrated in cognitive outcomes. Our future research efforts will look at neurologic, endocrine, and cognitive outcomes in these patients, as well as sleep disorders and obesity, very important things to follow in children with craniopharyngioma. I'd like to thank my surgical colleagues at St. Jude, Rick Boop, Paul Klimo, and Nir Shimony for their support in this research. Thank you.
Thank you, Tom. Great work. Any questions? Yes, go ahead.
Any questions? It's supposed to be up there.
But we have 2 minutes.
So the question is, what do we target? We target the cyst and the solid component. And then it's something that's not often talked about is that even in a patient who's had a resection, we're also going to cover the tumor bed because we can't go back and deliver another course of radiation or match up one treatment to the other. So in a patient who has a residual tumor in the tumor bed, we're going to target the entire volume. So we do include the cyst. I think that addresses your question.
Great summary, Tom. Tremendous experience. You mentioned that there's no lower age limit for radiation at St. Jude's. So how do you make decisions when a 1.5-year-old comes in and you're talking about it with the surgical team and a multidisciplinary conference, when to maybe do surgery and hold off on the radiation until they're older, or radiate them right away? I imagine that's a good discussion point. A lot of equipoise about that.
Well, fortunately, I can say that is the rare case, okay? But we wouldn't have a problem treating a 3-year-old, and we have quite a few of those in our series. And I think we're not against gross total resection. It's all about patient selection, right? And of course, we would like to defer radiotherapy in a patient under those conditions. And we also have put in catheters and done aspirations over time until they've gotten a little bit older, or we've understood how dynamic that cyst might be.
Excuse us. We have a confusion. The question and answer section will be at the very end of the session. So could you please excuse us?
Thank you.
Well, thank you so much, Professor.
Okay.
I would like to introduce Dr. Christian Blomfield with the topic scoliosis and neurosurgical lesions. What do I do with the caries, hirings, or tether cord?
Okay. Thank you for inviting me for this talk. We were talking about scoliosis earlier on in this room today, so it's kind of fun to have a little more focus on pediatric spine. And that's what's great about pediatric neurosurgery. We can have a talk about craniopharyngioma, followed up with spine and hydrocephalus and whatever else follows through here. So whether or not you're the one correcting the pediatric scoliosis, you are going to get called about underlying lesions that they got found on screening MRI scans, syrinx, Chiaris, tethered cords. And is there a role for treating any of those? Does treating it make anything safer? Does it slow down the curve? What do you have to do with these type of things? And that's what we're going to be talking about during this talk here. I have no disclosures. I'm actually Tom's neighbor in the same state of Tennessee, only a few hours away, so you got two of us from the same state. Classification of scoliosis, we mentioned this earlier on today, and earlier on it was more about the sort of idiopathic cases where we don't know what the cause is, but with these ones, if we're looking at lesions, it's going to be more up at the, hang on, let me hit start here, there. More up at the CP, spina bifida, Chiari, neuromuscular type cases, that there's something underlying in the spinal cord that's causing the actual scoliosis. And so those are the cases that we're going to be focusing on today. The workup of scoliosis, generally speaking, history and physical, you're going to get x-rays as we see here. There's pulmonary function tests. And the MRI comes into play a little bit. If it's a normal teenager with a small curve and it came in after their growth spurt, we're probably not getting MRIs. We consider that idiopathic, although there is some role on if they're very large curves and if you're going to take them to surgery. But for the early onset cases, the ones below the age of 10, if it's a non-normal curve, so a left-sided thoracic curve, if it's a painful curve, abnormal neuroexamination, or is there one leg that's weak? Do they have pain, radiculopathy, things like that? Is there a curve that's been stable and small and then all of a sudden progressed really quickly outside of growth spurts? Other spine abnormalities, hemivertebrate, congenital issues, cardiac issues, renal issues, things like that. And ultimately, we get scans pre-op as well because potentially can find something that might make it safer if you treat it. But these are the reasons that we're getting those scans in these patients with curves. Overall, about 10% of them have something on the MRI scan. It doesn't mean we're going to do anything with that necessarily, but if there are those risk factors earlier on that I just listed, it goes higher to maybe 14 to maybe 20% about it. And somewhere in the range of if you scan every patient that has scoliosis, there's about 3% that has Chiaris, about 4 with syrinx, less of the other things. And then obviously myelomeningocele, you know whether they have that up front because that's what the underlying etiology is. So there's not really a percentage with that necessarily. So we'll go through all these really quickly to say, hey, should we treat the Chiari? What do we do? What does that data look like? And in Chiaris, as we all know, the hindbrain herniation down, there's oftentimes a big syrinx with it. You treat that and the syrinx goes away. When we look at it with scoliosis, I can hear it clicking.
Can we advance it at the back?
There we go. Okay. So if there is Chiari malformation, scoliosis can be present in about 1/5 if there is no syrinx, and actually close to 2/3 if there is a syrinx there. So if you have patients with Chiari malformation, syrinx is very common. It may not be a large scoliotic curve, but it is something we often see. Most of the time, these patients are completely normal neurologically. And there was a question about whether or not the distance of the Chiari hindbrain herniation, whether it was the size of the syrinx, what it was, does that predict what the curve size is? And up to this point, we don't really think that there is. Some studies have shown that a larger syrinx may make the curve worse. Other ones say that it doesn't make any difference. So it doesn't seem to matter about what the size of the Chiari malformation or the syrinx is with the curve. But the ultimate question is there a way, if we treat the Chiari malformation, does that slow down the curve for our orthopedic colleagues to hopefully they don't have to fuse them, or the patient, we can put them in a brace and get through them up to when they're done growing. After surgical intervention, at least in this study, when they looked at all that was published a few years ago, about 1/3 of the patients improved. And about 1/5 of them stayed the same. So about 50-50 chance of if you decompress the Chiari malformation that the scoliosis would either slow down or get better. And so collectively, the ones that did better were ones that had smaller curves, so the curves less than 40 degrees, and in patients who are generally speaking less than about 10 years of age. And as we go through these, that's the general theme here. So you're going to take anything home from it. If you're going to treat the underlying Chiari, syrinx, tethered cord, or other things, generally the curve should be small and they should be young because there's still time for them to grow. And if the curve's already 50 or 60 degrees, it's unlikely to get down to a size that you're going to not treat that anyway. So when we're talking about these things, these are generally kids who are like 7, 8 years old with a curve about 30 degrees that we're trying to prevent from getting big enough that you actually have to do that surgical fusion to begin with. We looked at our single center study and then another multi-center study, same type of situation here. So there was an improvement in the curve magnitude if they're younger than 10 and if their curves are smaller than 35 degrees. So again, small curve, young patients. And again, when you look at the tonsils, the syrinx, all this other stuff, it didn't seem to have any difference about what size of all those measurements were compared to the curve itself. So it more has to do with the patient's age and the size of the curve. So look at Chiari's. A decompression of the Chiari may be offered to treat Chiari symptoms. Naturally, that's what, as neurosurgeons, we do. If there's a syrinx there, oftentimes we consider that a syrinx and we're decompressing that Chiari anyway. It potentially could minimize the need for future spinal deformity surgery, but generally speaking, it's in young patients and small curves. And then there's some literature out there that maybe if you decompress the Chiari and the syrinx, there may be less monitoring changes in the operating room, but that really hasn't been borne out too much. So again, young patients, small curve, treat the Chiari, hopefully slow down the curve, and maybe they don't need surgery. What about a syrinx? Same situation. If the patient has a syrinx, then they oftentimes have scoliosis anywhere from 1/4 to 2/3, maybe even more than that. So tells us that the range is really out there and wide. I think the problem is because we're not getting formal scoliosis films on everybody that has a syrinx, and also you don't know who has a syrinx out there if it's a very small, and they may live that way their whole life if there's not a Chiari with it. Historically, the syrinx was treated first because there was fear that as you straighten the spine out, if there was fluid in the spine, that could put pressure on the spinal cord from the inside and you could have a spinal cord injury. As we look further through everything, that's not necessarily borne out to be that case. So if you do have a syrinx, do you treat the syrinx before there's a fusion? Orthopedic says, hey, we need to do a fusion on this patient. There's a 3, 4, 5 millimeter syrinx in there. There's not a Chiari. There's not a tethered cord. Do you have to do anything about that? And the answer is probably not, from what we can tell, unless there's a Chiari and you're treating the syrinx because the Chiari's there. That's a different story. But if it's a syrinx by itself, at least from the papers that we've seen, you don't need to go ahead and do anything to the syrinx before they do their formal fusion. So drainage of a syrinx is considered. This is a rare situation with a syrinx by itself that's big enough to cause a problem. But it's considered if the patient has a large expanding lesion, a neurologic defect as a result of the syrinx. And again, in patients under the age of 10, if it's a very large syrinx, maybe you would consider drainage. But most of it has to do with the Chiari anyway, and you're decompressing the posterior fossa, not addressing the actual syrinx itself. So the take-home to this is you really don't need to do anything to that syrinx before they do their formal fusion. So just leave it there and go ahead and fuse them. Tethered cords is going to be split up in myelomeningocele, which we'll talk about in a minute, and more less complicated fatty phylums. What do you do with this patient whose conus ends down around L4 and there's a big piece of fat in a phylum? Does it prevent it, and do you have to do anything about it before the formal fusion happens? The first thing is the conus position in patients with scoliosis, at least from what we can tell, is about the same as in the normal population. So it's still somewhere between T11 and L2 in that range. Sometimes it's a little harder to count because the spine is coming in and out on those scans, but otherwise it's in the same range. In this one, again, it didn't seem to be any sort of correlation between the position of the conus, the type of deformity. So sometimes you see it, sometimes you don't. And again, same thing is that the conus position is in the same position in controls and patients with scoliosis. So when you're counting in your mind, it's the same as what you would consider in a patient who doesn't have scoliosis. Does untethering the patient or cutting that phylum prevent the scoliosis from worsening? In studies, it's again about 50%. So about 50% of them get better or stay the same, about 50% of them get worse. And again, the same theme about this is that the ones that are less than 35 degrees up top and a younger age from the study down below seem to help the best. So similar to Chiari's, less than 35 or 40 degrees, younger than 10, go ahead and untether them. It may slow them down enough, or especially, which is what I tell my patients, if you're looking at a 40-degree curve and they're only 7, you can't fuse them at that point anyway. And you're trying to get them at least until they're older to do one fusion instead of growing rods or other things. So if you can cut their phylum and slow them down and buy a few years, you may not get out of the fusion, but you may be able to get them older to get them in there, and then it may only be one other operation. So tethered cords, fatty phylum. Do you have to untether before the fusion? Probably not. So if this is a patient who's having no tethered cord symptoms, there's a fatty phylum and the conus is a little low and the curve is 60 degrees and they're fusing them anyway, just go ahead and fuse it. If you're trying to prevent it because the curve is smaller or by time, then you think about doing it in a patient who doesn't have symptoms. So kind of the two ends of this. Myelomeningocele, a little bit of a different story. Scoliosis in this is reported anywhere from 1 in 4 to nearly 100%, depending on where the lesion is. As a lesion goes up the back, scoliosis becomes more prevalent. So in thoracic lesions, about 100% of those patients are going to get scoliosis at some point. Just depends on how bad it is. Prevention with this, with patients who have had curves of 40 degrees or thoracic levels, they're all going to need fusions afterwards. And even if you untether them, it's not going to slow it down. So similar to before, if it's a smaller curve or if it's a lower curve, so a lumbar or sacral region, sometimes you can untether them up front, again, to bide time or to try to slow it down. If it's a thoracic level curve or thoracic level lesion or a big curve, they're going to go on to their scoliosis fusion likely anyway. The question then becomes do you have to untether them beforehand? Not too long ago, every patient that had spina bifida that was getting their formal fusion, they called neurosurgery to untether first because they thought it would make the case safer and then go on with the fusion. And Rich Anderson is sitting here in the audience. He helped answer this question of do you have to untether them before the operation? The answer from what we can tell is no. And in fact, the patients who underwent untethering first actually had worse outcomes with more infections, more return to the OR, more blood loss, a lot of other things than the patients who just underwent the fusion itself. So if the patient isn't having symptomatic spinal cord tethering symptoms, and they're going to undergo a fusion anyway, just undergo that fusion. There's no need to untether them up front. If you have to for some reason, let's say they are having tethering type symptoms and you are going to untether them, is it better to do it at the same time or 2 separate times? And the ultimate answer is, from what we can tell, if you can, do them at the same time. It's one surgery, it's one opening of that incision that has oftentimes been operated on multiple times before. The skin and soft tissue generally isn't that good, and the patients who underwent a single stage untethering and fusion actually had less rate of complications than those who they were split up. So again, you don't really need to untether them unless there's a reason to, but if there is, if you can do it at the same time, it actually has better outcomes than if you split them up on 2 separate days. So in summary, wrapping all of this up for a Chiari and a patient with a Chiari malformation without a syrinx and scoliosis, decompression of the hindbrain may be considered. Generally speaking, in young patients, so less than 10, small curves less than 40, and that may lead to slowing down the actual deformity or actually improving it. With a syrinx, if it's an isolated syrinx, it's unlikely that you would need to be that you'd need to drain this. And if they're going to undergo their fusion anyway, just go ahead and do it.
Dr. Blomfield, you have 1 minute left.
Perfect. For a tethered cord in patients with scoliosis, a presentation again, a tethered cord release of fatty filin may be considered in younger patients in smaller curves. And if they're going to undergo their fusion operation, you likely don't need to untether them up front. And for spina bifida myelomeningocele in patients with small curves or younger, that may slow things down. And you likely, again, do not need to untether them before the operation or before their fusion unless there's tethering symptoms. If you do have to untether them, try to do it at one stage because that limits complications. So thank you very much.
Does anyone have just one question, please?
Thanks, Chris. That was great. Can you comment on, is there any role for spinal column shortening in this as a means of functionally detethering?
Yeah, different topic in some way. Yeah, and that's a whole nother thing. And what he's saying is that instead of directly untethering the spinal cord at the bottom and going in where there's already been multiple operations, there's some thought that if you shorten the spinal column, take a piece of bone out, generally around T12, and shorten the spinal column, that'll functionally release tension off the spinal cord as well and have the same impact as untethering the spinal cord itself. I do think there is a role for that. I think it's more on patients who have lipomyelomenigoceles and everything is stuck in there and you can't really get a good untethering. I think it's ones that are better on redo multiple time operations. So ones that you've already untethered once, you've gone in there, you know what it looked like the last time, you feel decent about it but not great. And I also think that in the adult patients, that for those of you who deal with adult patients as well, when you get a 35-year-old who has had 4 untethering operations, sometimes it's easier to go away from where all that scar tissue is if you're used to doing vertebral column shortenings, and take a piece of bone out from T12, put 2 screws above, 2 screws below, and shorten them. So I do think that there's mounting evidence that it works close to as good as direct untethering, and in many ways has a different type of complication profile, less CSF leaks, less wound issues, but now you're fusing people who may have not otherwise need a fusion in there, and if their alignment isn't perfect, then you may be causing problems in the future. But for me, it's generally multiple redo operations and older adult patients. Yeah.
Thank you. All right, I'd like to invite Dr. Richard Anderson to the podium to speak to us about intraoperative neuromonitoring in pediatric deformity surgery. Welcome, Richard.
Thanks, Amal. I'd like to thank the committee for inviting me to talk today. We're going to talk a little bit about something that's was very frustrating to me in my practice, and so we tried to do a study to figure out some information about helping us determine how to handle it. So what we're going to talk about is in patients, pediatric patients, when you're doing deformity surgery, occasionally you'll have a situation where you lose all of your signals, your SSCPs and your motors, and you may decide to abort the case. And then the question is, well, in that situation, what's the clinical outcome? Because when that happens, it's hard to know what to tell the parents, it's hard to know what's going to happen or tell everyone, and then when to go back to the operating room. So I'd like to really thank my colleagues. This was a labor of love. This is like about a 5-year study from inception to completion. This is when I was still at Columbia. We were doing a lot of work there. And then Colorado and CHOP and CHLA and then Cedars-Sinai. All these people here played a large role in contributing to these patients. So intraoperative neuromonitoring has been shown to help reduce the risk of spinal cord injury during deformity surgery. And as I mentioned, when there's a significant reduction, it's a little bit different for each person, but typically if you have a meaningful reduction, then you may decide to abort the case. The goal of this study was to investigate the correlation between the timing of neuromonitoring loss, the clinical examination, and the subsequent normalization of the signals to try to answer the question, or as best as we could, when is it safe to go back to the operating room? So this is a multi-center, multi-study, retrospective study. We took pediatric patients less than 18 years of age who are undergoing deformity surgery, and every patient in this study had their deformity surgery aborted. So it's a very select population of patients. We're not talking about kids who went to surgery, had monitoring changes, raised the blood pressure, did a correction, decompression or something like that, got the signals back and continued the case. These are only patients whose case was aborted because of the loss of signals. And with all those centers together over about a 15 or 20 year period, we had about 66 patients. Again, we mentioned the locations. So we looked at everything we could think to look of in terms of preoperative data, all the demographics, ambulation, what type of etiology of the scoliosis. We looked specifically with the intraoperative data. We wanted to know the type of neuromonitoring, what type of loss there was, whether there was any signal return toward the end of the case, if an intraoperative wake-up exam was done. And then post-operative, we were really looking at the clinical exam, when patients returned to the operating room to see what worked out, and when they did go back to the operating room, whether they had monitorable signals or not. You can see the demographics here. Most of the patients were young teenagers and a real variety of different types of scoliosis here. So phase one, so we'll divide the results into 3 phases, because when you're dealing with the monitoring, it's really complicated, because you got SSCPs, you got motors, you got partial loss, you got complete loss, you got unilateral loss, you got bilateral loss. So let's see if we can put this all together here. So this is talking about what loss happened during the initial surgery. So you got motor evoked potentials on the left, you got SSCPs on the right. So as you can imagine, there was no patient in this study that had stable motor evoked potentials, because if you had stable motors, most of the time the surgeon's going to continue that case. So all the patients had a loss of motor evoked potentials. The majority, as you see, had complete loss. That was statistically significant, which makes sense. If you have complete bilateral loss of motors, you're going to be really nervous as a surgeon, and you're going to have a higher chance for reporting that case. Perhaps surprisingly, the majority of cases, SSCPs remain stable. About 2/3 of the patients, SSCPs remained stable throughout the duration of the case. There was a small portion that had complete loss, only 8 patients, which you can see in the red bar on the right. So the next question you're going to ask me is, well, okay, well, did those signals, and how many patients did those signals return? So when you're looking at return of signals, the good news is that even when you have complete loss of motor evoked potentials, the majority of the time, the signals come back. And this is without doing it, this is just aborting the case. This isn't doing further correction or decompression or anything. This is just aborting the case. Did those signals come back? And you had in 9 of the patients, you had full return of the signals, you had partial return of the majority. There were only 7 patients out of 66 where you had complete loss of motor evoked potentials, and there was no return. In terms of if you had partial loss, it was even better. So if you had any partial loss, then in every single patient, you had either full return or continued improvement of signals by the time you exited the operating room after aborting the case. All right, phase 2, post-operative exam. So what does this all mean in terms of a clinical outcome? What are you going to tell the family when you walk out of the operating room and you lost signals and you had to abort the case about how their child's going to do? So the good news is that patients overall do well. So in terms of a sensory exam, 91% of had a normal sensory exam within the first 3 days. That makes sense because, as I mentioned in the previous slide, the majority of patients didn't have SSCP loss to begin with. Okay, but in terms of the motor exam, it was also pretty good. 86% of the patients had a return to a baseline normal exam within 3 days. So that's really good information. You got a patient, you got complete loss of motor evoked potentials. You don't know what's going to happen. You could, based on this study, you can come out and tell the family there's an 85% chance that your exams can be normal within 3 days. So just to look at that in a little bit different way, so about 1/3 of the patients had immediate postoperative weakness, but only 15% had weakness more than 72 hours. And when you look at, well, how do we know which of those patients are going to have a persistent deficit? There is a correlation, which you can see in the red bar there. If you lost bilateral SSCPs and motor evoked potentials, there was a statistically increased risk of having a delayed postoperative exam. And that makes sense. If you have complete loss of both your SSCPs and your motors, it's likely you have a more severe spinal cord injury, and it's more likely you're going to lead to a clinical deficit. So back to the operating room. The original question was, well, when is it safe to take kids back to the operating room? So we looked at everything we could look at to try to figure out, when you could go back to the operating room safely. Because what prompted this study was when I had a couple patients over the years where They wake up with a postoperative deficit. I follow them in the office. They come back to see me a month later. Their neurologic exam is totally perfect. Their motor center is totally perfect. I'm like, this kid's gonna be fine, take back to the operating room. Take him back to the operating room, spend 2 hours, complicated patients, anesthesiologist getting lines or whatever. We do SSCPs and motors, no monitorable signals. I've just wasted an entire day. I've wasted 2 hours of that kid under anesthesia, and I got no signals. And then I got to make a decision about whether I got to proceed with no signals, flying blind, and go do wake-up exams the whole time, or whether I'm going to abort the case again and reschedule. And that's what was so frustrating. So to try to answer that question, the only thing that was statistically significant was basically if you had complete loss of motor evoked potentials and SSCPs. The other one, return of motor exam, that makes sense. The longer the exam takes to get back to normal, the less likelihood is you're going to have a normal signals when you go back to the operating room. So this is the best graph we could put together, which is the black line is basically time to return to motor function, and then the red line is basically patients with the monitorable signals. So you see that there's a big increase at the beginning. We don't know, this study doesn't answer the question whether those two lines ever cross. And the reason for that, even though the design of the study was to try to answer the question, when is it safe to go back to the operating room, I can't give you a good answer to that question, because in order to answer that question, we'd really have to take all these patients who had aborted surgery, take them back to the operating room at 1 month, see if there's signals, 2 months, see if there's signals, 3 months, see if there's signals, to see when the exact time frame is. But I think this is helpful because it tells you that within the first 2 weeks, after the first 2 weeks, it really plateaus off. So there's a very good chance you're going to be able to take the patient back to the operating room if their neurologic exam returns to normal within 2 weeks. So there are a lot of limitations of this study. It's a small cohort of patients, but it's a very rare problem. We only assess patients who had cases aborted, so there's selection bias. Again, I can't tell you anything about, when you lose signals in the operating room, if you decompress or do this and you get signals back, don't abort the case. Those patients weren't included in the study. There's a lot of subjective determination to abort cases. My threshold for aborting a case may be different than Chris Bonfield's or others in the room. Timing of the operating room is highly variable due to multiple factors, when there's OR time, how the patient's doing, medically stable, all that kind of stuff. But to conclude, our data suggests there's a correlation between combined SSCP motor evoked potential loss, the magnitude of the loss, the time of clinical recovery, and the time for return of signals. If there's a bilateral loss of SSCPs and motor evoked potentials, there's a statistically increased likelihood of having a delayed motor exam that takes more than 72 hours to return and not getting signals when you go back to the operating room. It looks like the percentage of those patients with monitorable signals levels off around 2 weeks after the surgery. Again, thank you, my colleagues, and thank you for your time.
Thanks, Rich. Great study and obviously very helpful. Any questions?
Did any of these patients have a permanent severe deficit?
None of the patients in the series ended up, some of them took a while to recover, that 15%, some of them were like 6 months later, but no one ended up with a permanent deficit. Great question. Yeah.
What would you do if you had a new patient going for scoliosis correction, and after anesthesia, there are no signals?
Yeah, young patient, young child?
Young child.
Yeah, so I've seen that a couple times, especially with syndromics, like big cervical spine deformities, 2 or 3 years of age. So what I like to do is, it depends a little bit on the deformity. I would abort that case, I wouldn't even start, and I would put them in traction and correct the deformity in traction, because then you can clinically examine them and you can make sure that as their deformity is correcting, that their neurologic exam is stable, and then you know where you can get, and then take them to the OR and fix them.
So apart from that case which you described, would the SSCPs have altered or changed your surgical management intraoperatively?
I'm just to understand the question. Your question is if SSCPs changed during the surgery, would that alter?
Yeah, so the fact that you had the SSCPs and either disappeared or were present, did that alter your surgical management?
Yeah, so I mean, if I lose, it's motor evoked potentials are much more sensitive than SSCPs. I'm trying to think if I've ever had a case where I lost SSEPs with a deformity case without losing motors, and I'm not sure that's ever happened. It's different if you're doing intramedullary spinal cord tumors or something, you're going through posterior column, that's a totally different scenario. But for deformity surgery, I'm not sure I've ever had a case where I've lost or had a decrement in SSEPs without a decrement in motors, because the motors are so much more sensitive. Chris, have you already had a case like that? Or has anybody in the audience had a case?
I think probably also what he's sort of asking is saying, if you lose motors but keep SSEPs, would you continue on? Does this change anything?
Yeah.
It doesn't. I'd still go, but I feel more confident in knowing the family that the kids are going to do fine and we can come back sooner, I think.
Yeah, it's difficult. I think it's really difficult to do a big deformity correction without having motors. I think that, at least in our medical legal environment in the United States, that you could get in trouble if you did something like that and the kid woke up with a problem. But I think that change in the signals tells you that there's something going. That cord is at risk. There's some ischemic component, or it's not happy. That spinal cord is not happy. And so to do anything further in that situation, is probably more risky. And I think it's better to abort and delay and come back. I agree.
Final question at the back.
Do you ever use D-wave monitoring for scoliosis patients?
Yeah, DNEPs, it's a great question. So DNEPs are great in a lot of ways. They've largely been huge. The best series or the best understanding of DNEPs, I think, is the St. Louis experience, because they used that for decades. They've moved away from that to standard, transcranial SSE or motors and so forth. DNEPs are very helpful to map where the spinal cord injury is occurring. So the knock on DNEPs is that they don't monitor the motor pathways precisely. That's well known. It's an antidromic, it's a feedback loop and so forth. So it doesn't monitor the motor pathways specifically, so I don't think it's a good idea to use DNEPs without transcranial motors. I think your best scenario is transcranial motors and SSEPs. But if you're doing a high-risk surgery, 3-column osteotomy, major deformity, it's really nice to be able to have your technicians be able to do DNEPs, because you've got a big long curve, you've got a double curve, you're doing a VCR up here, you're doing a major correction down here, and you start doing your VCR, you lose signals, but it may be because something's happening lower down or compression on the concavity. So it helps you be able to map where along the cord in your surgery the neurologic deficit is the spinal cord's not happy. So I think they're very helpful, but in unique circumstances.
Thank you so much. Now, I would like to introduce Dr. Chris Durham with coronary cervical junction surgery in children.
Ladies and gentlemen, I'd just like to say thank you very much for the opportunity to speak today in Cape Town at the WFNS on craniocervical junction surgery in children. So my name is Chris Durham. I'm a consultant neurosurgeon from Leeds in the UK. I went to the masterclass on craniocervical surgery this morning and was quite humbled, and it did induce a lot of thought-provoking news, which we can discuss later on. So, as an introduction, the craniocervical junction is uniquely designed to provide stability and mobility in the head and neck region, and protect some of the most critical neural and vascular structures in that area. And therefore, consideration for craniocervical surgery warrants a philosophical, biomechanical, and anatomical knowledge in order to undertake this safely. The craniocervical junction is at increased risk in children for various reasons, namely a relatively underdeveloped neck musculature, disproportionately large cranium, and shallow atlantal articulations. There is also a high laxity of the occipitocervical ligaments and joint capsules. Superimposed congenital or acquired pathologies can exacerbate and accentuate these factors cause it, leading to instability. The junction is comprised of two important sets of joints, the C0, C1, or ball and socket articulation, which provides 21 degrees of flexion extension, and the convex C1, C2 articulations, which provide approximately 50% of axial rotation in the spine. The stability is maintained by several sets of ligaments. The common one is the transverse ligament, which stabilizes in a horizontal fashion. Stability has been well described historically by Punjabi and White, but there is a new theory about relative to craniocervical junction surgery, and that is about vertical instability as well as the horizontal or translational instability described. So the indications, the techniques and the pitfalls stem from adult patients. And we know that fusing segments of the spine can limit growth or cause secondary deformity at adjacent segments. Anatomical variations anatomical variations associated with syndromic CVJ anomalies complicate surgery and sometimes makes instrumentation very difficult or not possible, or doing something bigger than what you had planned to do in the first place. So some of the indications for atlantoaxial fusion include congenital, developmental, and acquired pathologies. Moroto has elegantly described a treatment algorithm describing neural compression and instability, and in the context of that, offering a fusion and decompression procedure. Where there is neural compression without instability, a decompression can be undertaken by itself. However, this was fiercely debated this morning at the masterclass. In Leeds, we have conducted a retrospective review of all of our data, and that is over approximately a 10-year period. And we recognise that the numbers are small, but this is endemic of the pathology that we're treating, and it is a rare type of disease process. So the results, out of 21 cases that we have surgically treated, 12 were treated by a C1, C2 fixation. That was a Goel-Harms technique, and 9 underwent occipital-cervical fixations. Subsequent to the publication this year, we've undertaken 2 further C1, C2 fixations. We have been doing this jointly, so 2 surgeons operating in our institute. One is a dedicated paediatric neurosurgeon, and the second, somebody who has an interest in CVJ pathology, predominantly in adults. And we feel this has been particularly helpful to enhance safety. The median age of the patients that we treated was 8, and the etiologies range from trauma to os odontoideum, congenital anomalies in 6, and post-infectious instability in 3. We encountered no intraoperative complications, specifically no vascular arterial injury. One patient did develop a pseudomeningocele post-operatively, which was managed conservatively. One patient developed bulbar symptoms on follow-up, and this was due to ongoing compression from basilar invagination, and that required us to undertake a transoral resection of the dens. The neurological improvement was observed in 8 out of 12 patients for the C1, C2 fixation, and 3 out of 9 for the OC fixation. And I think the reason for that is that almost half of the OC fixations were undertaken for traumatic pathology. Bar the patient that developed bulbar symptoms, most remain neurologically stable after surgery. And we saw reduction in fusion rates in over 90% of patients at 34 months follow-up. One patient requested to have their instrumentation removed, and 7 years from the time of injury, the patient had clinical and radiographic stability. For 5 of the 21 cases, we've started to use neuronavigation, and neuronavigation is something that we use all of the time now to undertake these procedures. We feel that as though it provides a safe adjunct and makes things better. As well as a transoral resection, we've undertaken an anterior den screw fixation for a traumatic case. This is rare, and again, it's born from adult practice. It preserves axial rotation, but it's dependent on having an intact transverse ligament. So in theory, this is an approach from the C5, C6 level. It can be quite challenging, particularly in adult patients if they're barrel-chested. A guide wire is placed under biplanar X-ray across the fracture fragment, and a lag screw goes into the distal fragment to get compression and enhance fusion. So this is a 15-year-old boy who was initially managed conservatively, had a non-union and underwent a peg screw fixation. And 3 to 6 months post-operatively, we noted fusion across that segment. So historically, atlantoaxial fusions have been described by Brooks and Galley, wiring techniques utilizing autologous ribs and iliac crest graft, which is associated with donor site morbidity. This has been superseded by techniques such as transarticular screw fixation and the gold standard, which we all subscribe to, the Harm's goal technique of putting lateral mass screws into C1 and either pars or pedicle screws into C2. Trying to circumvent the problem with a pars or pedicle screw, we have had to use translaminar screw techniques if it's not been possible to insert the classically described C2 screws, and this does afford good biomechanical stability. The only problem is that you have to offset the rods because the tulip heads come too close together. Occipital cervical fixation is reserved for C0, C1 pathology, or if there is difficulty or it's unsafe to place a C1 screw. It is more restrictive in terms of flexion extension and rotation, and therefore we try to avoid it if possible. Occipital cervical dissociation is a rare condition. It's often associated with high mortality. This was a 3-year-old girl who was involved in a road traffic accident, and she underwent an occipital C1, C2 fixation. We decided to put instrumentation into 1 and 2 to spread the load to prevent or to reduce the risk of C2 failure. This is an intraoperative video of a OC fixation utilizing neuronavigation for a complex Chiari malformation. So this is just exposing the C2 articulations in a subperiosteal manner, marking the foramen magnum decompression, sizing the plate, and then using the navigation to really pinpoint the entry point and drill the track with a high-speed drill. There is a movement or a drift with this system, and you have to correlate both anatomical landmarks with the navigation. The instrumentation that we use is pediatric related, so the screw diameter is slightly smaller. Foramen magnum decompression done in a standard manner with some debulking of the cerebellar tonsils and resection of both the tonsils before closure. And then finally, contouring and inserting the occipital plate and decorticating with lots of bone graft to aid fusion. So in conclusion, undertaking CCJ surgery requires a fundamental awareness of the anatomical variations and meticulous planning preoperatively using all imaging modalities, flexion extension radiographs, sometimes flexion extension MR, CT. we've utilised assistance with intraoperative neuronavigation. There is well-described use of neuroendoscopy to help this. The learning curve is steep, but I think that will become, will become something used more often. And trying to minimise the instrumentation to the least possible levels to avoid adjacent segment issues. And finally, trying to develop research into development of tissue-engineered constructs which can be reabsorbed by the body in time. And I'd just like to thank my neurosurgical colleagues for their help and being involved, allowing me to be involved with this work, being more of an adult neurosurgeon. Thank you very much.
We have time for just one single question.
Where do you dock your neuronavigation?
Yeah, good question. So we use a Mayfield and put the array really close to the head. As close on the Mayfield holder, yeah. And then do your 14-point registration on the lamina. But we'll register each lamina independently.
Rich?
When you do that, when you use navigation, do you do your spin with the retractor in place?
No,
the
so
young
we
children?
don't. We're not that wealthy. We don't have intraoperative. We get a CT pre-operatively,
Okay.
and we use that to do the navigation. So we're registering the landmarks there and then.
Based on-
Thank you. Do you find the need to capture C1 every time you do occipital-cervical fusion? Do you guys do that generally?
No, not all the time. It depends. If there is assimilation of C0 and C1, then we wouldn't. We would just put a plate and go down to C2. For trauma, where there's disruption of the ligamentous complex between C0 1 and 1 and 2, we would to bridge the load.
Okay, thank you very much.
Thank you.
Our next speaker is Dr. Francesco Sala, speaking on the latest developments in intraoperative neuromonitoring in pediatric neurosurgery.
Thank you, good afternoon, and thank you to Tony Figage and the organizing committee for giving me the opportunity to contribute to this session. So what I would like to do is just to share with you some of the development of neuromonitoring in the field of pediatric neurosurgery over the past several years, trying to focus on the most recent advances, and I will just shortly touch base on some of the potential future techniques that I will address more specifically tomorrow morning in the other pediatric neurosurgery session. So when I look at what was the state of the art of neuromonitoring in pediatric neurosurgery more than 20 years ago, it was quite clear at that time that this was an emerging field within neurosurgery and pediatric neurosurgery as well, but there was little experience. There were very few pediatric neurosurgical centers performing neuromonitoring routinely, and most of the experience came from the adult neurosurgery setting. Looking back 20 years later, it's obvious that we have made major progress and stepped forward. There have been an evolution in the use of this technique, but to some extent, after a strong implementation in the late 90s and early 2000s, the field has to some extent plateaued for many years, while in the last 5-6 years there have been some new techniques, and I will shortly touch base on this. So in brain tumor surgery, the typical mantra in adult glioma surgery is that we know that the extent of resection correlates with the survival, but unfortunately this correlates also with the risk of neurological injury, and that we know that neurological morbidity impact negatively on the outcome. So the mantra has also been to maximize resection while minimizing morbidity. This of course applies also to pediatric neurosurgery, brain tumor surgery, and this is where there is the rationale for the use of neuromonitoring. However, 20 years ago, the vast majority of the literature focused on the use of monitoring in epilepsy rather than brain tumor surgery in children. There were only anecdotal reports on cortical and subcortical mapping in children with brain tumors, and Paedfield technique, particularly in North America, was the standard technique used. So there were no data on motor evoked potential monitoring, because with Paedfield technique you cannot perform MEPs. So typically this is still the old Paedfield technique, which is still nowadays the gold standard when it comes to language and cognitive mapping. The goal here is to negatively interfere with brain function. This is typically performed during awake surgery using a bipolar stimulator. The problem is that when it comes to motor mapping and monitoring, there is no need to use a Paedfield technique anymore, because this has been substituted many years ago by the so-called motor evoked potential short train technique, which has several advantages over Paedfield technique, particularly in the children population. The short train technique, here the goal is to induce a positive response and muscle contraction. This allows for both cortical and subcortical mapping as well as MEP monitoring, and typically is performed during a sleep surgery using a monopolar stimulator. Now, this is a large study, probably the largest study from the Tel Aviv group with Jonathan Roth and Shlomi Costantini. They compare the two techniques in a group of children with brain tumors. It's quite evident that the motor mapping success rate was much higher using the short train technique, 84%, as compared to 25% using Paedfield technique. Not only, but the youngest age where monitoring, when mapping was successful, was about 3 months with the short train technique versus almost 8 years with Paedfield technique. So I think there is now strong evidence that in the pediatric age group for motor mapping, the short train technique is much more robust and valuable than Paedfield technique. And this has been progressively accepted and acknowledged also in the field of epilepsy surgery. This is a nice paper from the Toronto group, where they compare extraoperative and intraoperative mapping using cortical grids, but actually they were looking at two different techniques. So they were using a Paedfield technique for the extraoperative and the short train technique for the intraoperative motor mapping, and they conclude that indeed with Paedfield technique you have much more after discharges and seizures as compared to the short train technique, and also the mapping information was much higher using the short train of 5 rather than the Paedfield. Motor evoked potential monitoring is definitely feasible in very young children. This is a study focusing on in infants less than 3 months of age. The success rate was very high. This was mainly a study on tetracord surgery, but there were also children with brain tumors involved. So there is now, I think, good evidence to say that MEPs is a standard of care, and it's feasible and reliable also in very young children. Now, one of the problems, of course, in the pediatric age group is awake surgery. And whether we like it or not, but the evidence is there that awake surgery is still very, very challenging in the pediatric age group. This is a recent review which pointed out that in the last 65 years, there were only 9 cases of awake surgery in the pre-adolescent age group, and 50% of these cases were recently reported by the Toronto group. But even if you look at the adolescent age group up to 19 years of age, in the literature, there are no more than 50 cases described. So awake surgery in children remains a challenge. And that's why we have been trying to investigate other technique. I will more specifically touch base on this tomorrow morning, but trying to investigate novel techniques to assess the connectivity, brain connectivity in the sleep setting. And you can do this in 2 different ways. One is to condition the function of a specific area. For example, you can condition the function of the primary motor area, applying a conditioning stimulus to either the parietal and frontal lobe. This allows us to investigate the connectivity between the parietal and the frontal areas to the primary motor cortex. So we look into the connectivity between the parietal lobule and the motor cortex. The other thing you can do is to look at how cerebellar stimulation modulates the output from the primary motor cortex. This is important because this technique is most likely exploring the dentato-thalamocortical pathway, which is the same pathway involved in cerebellar mutism. So there is an attempt now to find a way to monitor neurophysiologically in the operating room this pathway to see if we might eventually be able to detect and possibly prevent in cerebellar mutism. And the other possibility is to perform the so-called cortical evoked potentials, where you stimulate and record from 2 different areas of the brain. This has been investigated in the awake setting for monitoring the arcuate fasciculus by stimulating from Broca and recording from the so-called Wernicke and vice versa. We have tried this recently in the sleep setting. All these preliminary and pilot studies were done mainly in adult patients, but of course they have implications for pediatric neurosurgery. We'll discuss this more in detail tomorrow morning. Moving down to the brainstem and to the posterior fossa, we nowadays have a number of techniques that we can use to map the brainstem and to monitor the different pathways within the brainstem, from the auditory, sensory, corticobulbar, cortical spinal tract. Something which is probably particularly relevant to pediatric neurosurgery is that apart from using mapping to identify the safe entry route to intrinsic brainstem tumors, of course we see many children with foreventricular tumors, medulloblastomas, ependymomas, and this tumor can infiltrate the ependyma. So you can use mapping now to decide when to stop. The same way you use mapping operating on a brain tumor, where you use subcortical mapping to decide where are the functional boundaries that you have to respect subcortically and where you have to stop your resection. So this is important because we can remove the tumor as long as we don't have a positive mapping result. So you can look at the response from your upperglossal, glossopharyngeal, and vagus innervated muscles. And then as soon as you get a response with very low intensity, that means that the nuclei are just a few millimeters underneath. And so it's better then to stop in order to avoid post-operative neurological complication. Of course, we have to discuss also the oncological implication of that. But still nowadays, we have this technique which allow us to address this surgery safely. Now, one important point is that for many, many years, when we were looking at the lower brainstem, at the lower cranial nerves, of course, we were trying to prevent dysphagia, dysphonia, and loss of the coughing reflex. But all the techniques we had were only monitoring or mapping the efferent motor pathways of these reflexes. So we didn't get any information on the sensory pathway, but we know that clinically wise, if we injure the sensory arc of these reflexes, we can still have a clinical problem. Now, very recently, just a few years ago, the so-called laryngeal adductor reflex monitor was introduced in clinical practice, particularly to preserve the superior laryngeal nerve during thyroid surgery. But this technique has strong implication also for neurosurgery and pediatric neurosurgery, because basically by stimulating air recording from the vocal cords with electrodes mounted in this endotracheal tube, you can monitor both the motor and sensory arches of this reflex. An important point is that this reflex is mediated at the level of the lower brainstem, involving the nucleus ambiguus, the reticular formation, the nucleus tractus solitarius. So now we have a technique which can provide us information also on the sensory afferent pathways at the level of the lower brainstem. And although this has been mainly tested in adults with brainstem and cerebellopontine angle tumors, there are the first anecdotal reports also in pediatric cases. Thus, this may eventually become a more useful techniques in the years to come to prevent deficit of the lower brainstem. And finally, there's been a lot of enthusiasm a few years ago for the possibility to directly map the motor pathways, the cortical spinal tract, when removing intramedullary spinal cord tumors, passing the idea that you can stimulate the spinal cord, and if you get a motor response, then you are hitting the cortical spinal tract. Unfortunately, this has proved not to be true, because you can get a response, a massive response, even if you stimulate the posterior, the dorsal column pathways. And this is because you antidromically activate the somatosensory evoked potential pathway. So you might either get a motor response because you are stimulating the cortical spinal tract, or because you are antidromically stimulating the sensory pathway. There are these yellow interneurons which connect this with the alpha motor neuron, and you will get a motor response. Now, particularly thanks to veteran deletis and Catherine Seidel, we have developed a new technique where basically you can apply 2 stimuli to the spinal cord 60 milliseconds apart. And if you get 2 stimuli into responses, that means that you're really stimulating the cortical spinal tract, while if you're stimulating the dorsal column, you will get just 1 response, but not the response after the second trem. And this is because the interstimulus interval, those 60 milliseconds, follow into the refractory period of the interneurons. So that the second stimulus will not be able to pass through the interneurons. Therefore, if you're stimulating the dorsal column pathway, you will not have a second response. This is a little bit complicated monitoring-wise, but it is one technique that you can use to try to discriminate if you're really stimulating the motor pathways or the sensory pathways when you stimulate the spinal cord. And finally, we'll just like to pay a tribute to this gentleman to the right. This is Dr. Vedran Delitis. Some of you may have heard his by name. He was not a neurosurgeon. He was a clinical neurophysiologist, but he contributed enormously to the field of neuromonitoring, particularly in pediatric neurosurgery. He was working with Fred Epstein for 30 years in New York. And when I look back to the past 20 years of history of pediatric neurosurgery and neuromonitoring, it's quite amazing how most of the techniques we are using nowadays were developed by Dr. Delitis. So I think as neurosurgeon, pediatric neurosurgeon, we are very much in debt to him. And this is a picture actually of him here in Cape Town, all the way to the right for the International Society of Intraoperative Neurophysiology meeting a few years ago here in beautiful Cape Town. Thank you.
Thank you, Dr. Sala. Great comprehensive review of the topic. Any questions? Was that comprehensive? We don't have any questions. Okay, great. Thank you.
Okay, so we're going to proceed with Dr. Totimi with the topic question of also Ghanaian, one year's history.
Thank you. So first of all, a small disclaimer. This is my first Cushing's, and but the more I've spent time preparing for this, the more I've realized how privileged I might be, because this might be my last Cushing's. But it's rare. We say Cushing's all the time, so I sort of thought it was more common, and the Cushing's syndrome that we would see exogenously would be sort of something that we keep saying, but the Cushing's disease itself is quite rare. And to think that he first described it in 1912, and at the time he thought it was just a manifestation of something adrenal, and he didn't really link it to the pituitary. And then 20 years later, he would now finally link it to the pituitary. But again, he didn't think he didn't know about the ACTH. So it's only in 72 that ACTH is now discovered, and then it's actually named after him. It's still rare because, Cushing's syndrome is like 1 in a million, and Cushing's disease is, 1/10 of this. And then for children, it's even rarer, So, you can understand, as I've read a bit more about this, I realized that maybe I should talk about it because I might not get the chance to talk about it again. So, it's just, so I'm talking about this in the low middle income environment, and I want to discuss some of the things that I went through as we made the decision. But I think the key thing for me was that surgical outcome is so good, and that's what made us bold enough to do it. Now, it would usually give some kind of a warning, but this is in an environment where you're measuring the height, measuring the weight, and this is not exactly practical for most people. But the person I'm going to talk about is the one on the right. This is her as a 14-year-old girl with her twin sister. And this is like 2 years before everything happened, and everything is normal. Maybe if somebody had, been measuring, and nobody would usually measure, but they would have seen that maybe the weight was going up suddenly and the height was frozen. So the fact that it's rare meant that it would take another 2 to 3 years before she'd get to me. And during this time, she'd been in and out of hospital. They had been seeing this happening on her skin, seeing this increasing obesity, seeing these striae. She had been to a dermatologist over and over again, and at no point had it, started coming out that there could be something hormonal. So she lives in a city about 2 hours away from mine, and they had a visiting neurologist in the hospital, and he really just made a spot diagnosis because he saw her and he says, you need a CT scan, right? So this is when this girl comes to me, 16-year-old, just looking like this, right? And you can see the difference between 2 years ago and now, right? So at this time, she's hypertensive, she's diabetic, she is grossly ill. Cortisol was what we got. The other hormones were, normal. It will take about maybe a week to get back ACTH. So basically, the decisions were made just on the cortisol. So this was a CT scan. Now, I sat down with the relatives at this point. I'm like, this is Ghana. If you get pan-hypopituit, where I don't know what we're going to do. It's going to be difficult to, find the medications for you. It's going to be difficult to afford the hormones that you need. But this is a small tumor, and the risk is significant. I mean, the other thing was, it was going to be even difficult for them to afford an MRI. And so this decision was made just based on the CT scan. So, well, it was so it was two nervous surgeons who were in theater that day, my ENT colleague and myself, because here is this almost a microadenoma, and this is this child, and we don't know what's going to happen. And I'm sure you'd notice his telescope is very long, because our usual short telescope has poor optics. So we borrowed this from the urologists because it's HD. However, we realized something because it's how long it was. He was out of the way. The ENT was out of the way, so it was. I wasn't clashing into him, at the time, and I thought we were going to find something that would be easy to attack, but anatomy was pristine. There was nothing, and there was just something suckable. So we sucked it, and maybe because she got a bleed, we stopped. At one point we just hit a big bleed, and then we just packed, and then we stopped, and then we were like, okay, that's it. It's more like we didn't have the courage to go back, after the bleed. Well, we packed the space, some Surgicel and all that, and this was a CT scan we got. Now, this is not a CT scan I want to sit down with their relatives, to talk about, because it's almost like we did nothing, So 3 weeks later, so this is just post-operative. This is like 48 hours after surgery, and it did seem like we're going to get a good story to tell. 3 weeks later, this girl, the father sent me a photograph of her being able to wear slippers for the first time in a long time. And then this is her 3 months later in the operating room, in the OPD with her sister. So just some of the lessons that we learned, we're usually talked to about, do not treat the image, treat the patient. But I think this was really something where I didn't really see any change on the CT scan, and yet the clinical change was significant, and it's mainly the clinical change that reassures me that something good has been done for this girl. In this case, we made the decision to operate because it's so rare, it's so obvious, and we know that in children, 80% of them would be Cushing's disease, if it came to the explanation for the Cushing syndrome. We're going to keep following up because there's quite a high tendency that it will recur. But just the fact that, a neurologist picked this up, called me, and the teamwork is what has helped this child in the long run. And I mean, maybe I'll never be scared of, making a child pan-hypopit again, because, I mean, maybe children are resilient, but I'm not looking forward to the next cushions. It's so there are logistics issues, imaging, ancillary specialties. There's an adult endocrinologist who has been helpful. One day we might get a pediatric endocrinologist. The thing is, if I had made her pan-hypopit, affording hormones was going to be difficult. I mean, there's somebody who can't afford an MRI, so you can just imagine. And we needed to be ready for intraoperative hemorrhage risk. So conclusion, it's effective for, Cushing's disease everywhere. It doesn't matter where you are. And the collaborative part is really crucial to treat such rare diseases. We'll follow up, but we need much more work for, we have to adapt protocols to fit an environment where you are not going to be able to do a suppression test or able to do inferior petrosal sinus sampling and things like that. Right, thank you. And yes, you're invited to Zimbabwe next year. There's the Society for Neuro-Oncology Sub-Saharan Africa, and then ISPN in Toronto. Thank you.
We have some minutes for questions in this interesting case. Does anyone have any?
Just a comment. Good job,
yes.
Andrew Weiser from Atlanta. Great
right.
job.
Thank you.
I think proof of the pudding is in the eating, and
right.
you should be very proud of yourself.
Thank you.
Great case. Thank you for sharing. All right, our next and final speaker is Dr. Andrew Reisner, talking to us on TBI biomarkers in children. Welcome, Dr. Reisner.
Thank you so much. It's such a pleasure to be here. Looking at the schedule, it seems like I missed some excellent talks. I apologize. I was at with the trauma session. And I must say, walking into this room with fellow pediatric neurosurgeons, I just feel so much more at home here than I did there. But I know you won't share this with the audience in the other room. So thank you so much for inviting me. It's such a pleasure to be here. I'm going to be speaking on biomarkers, and can't thank you all enough. It is such an honor to be here with you this afternoon. I'd be remiss if I didn't thank three people who we all know and love, Tony Fiaggi, Nelson Owusiku, and Graham Fagan. This didn't just happen. They put a lot of hard work in it. So a quick preamble. Greetings from Atlanta, Georgia. For those that haven't been there, it's a city marked by civil rights and the Civil War. Children's Healthcare of Atlanta, a large tertiary care hospital, serving about 8 million, large neurotrauma program, hence my interest in neurotrauma, at least 400 TBIs a year, and a large concussion program. We have a translational lab, and I'd like to thank my colleagues who've contributed to this study, especially Drs. Blackwell, Leopard, and Churn, as well as Aliwa as well. Last greetings is from the WFNS Neurotrauma Committee. I'm currently the chair, about to hand over the baton, and would like to thank my co-chairs, Andres Rubiano from Colombia and Laura Lipper from Italy, as well as what I call my secret weapons, 33 individuals from 29 countries who did a great job. No disclosures, all pictures are with patient's permission, so here we go. So, if I was speaking to my colleagues upstairs in the trauma session, I'd probably spend a little bit more time on difference between pediatrics and adults. You don't need to have that lesson. What I am going to do, though, is speak about the potential role of biomarkers in TBI. And then I thought, just to sort of give this talk some structure, speak about pediatric research in generally. What are the challenges? pediatric research? How about next, researchers in pediatric TBI? And next, focusing on challenges in biomarker research with some conclusions. So, for those in the audience that are not familiar with TBI, if you're going to remember one slide, this is it. This is the slide that came out of the Lancet, and the squared column there is traumatic brain injury. This is, by the way, adults and children. And the incidence is purple, the prevalence is green, and so you have a look at, I don't have a pointer, the Alzheimer's disease. 1, 2, 3, small purple, low incidence. You live for a long time, high prevalence. With me? So you look at TBI, and both incidence and prevalence are much higher than everybody else. And I think for me, that speaks to the fact that TBI is not just an acute disease, it's a chronic disease as well. Again, something I don't need to tell you all, TBI is significant. TBI in children is significant, even though the absolute numbers are perhaps a little bit lower than other age groups, especially the elderly. It's substantial when you think in terms of YLLs, years lost to life, and years lived with disability. Interestingly, at the extremes of age, falls are the most common, and those are the brown ones over there that are shown in the different age groups. There are also regional differences. We know that our colleagues in India deal with balcony falls. Our colleagues in Singapore, perhaps more and more appreciation for abusive head injury, although I am convinced it happens worldwide. And in the United States, unfortunately, we're having a surging epidemic of gunshot wounds to the head in children. Again, this audience knows that there are age differences in developmental physiology. Interestingly, the neuronal population at birth is the same as adults, but there's dendritic expansion. In contrast, the white matter expands tremendously, and TBI at different ages can affect any of those processes. So what does that mean for us clinicians and surgeons? Well, you know, neonates have a thin covarium, which obviously has some implications. The fontanelle is open, but not such a great dissipator of ICP as we think it is. We do know that because of the decrease in myelination, often you get massive swelling of the brain with terrible cerebral edema rather than mass lesions in children compared to adults. Although let me quickly say that that is an overgeneralization to a fault. Of course we get swelling in adults. Of course we get hematomas in children. But generally speaking, this is more a problem in children, and no big surprise, we have different TBI guidelines. So for those that are not familiar with biomarkers, anybody here not used a biomarker? Can I ask you to put a hand up? Anybody not used a biomarker? Put your hand up. Okay. Well, I'll ask that question again in 30 seconds. If you've ever taken a blood pressure, measured a glucose, looked at an x-ray and looked at the CT scan with the tumor getting bigger, that is a biomarker. It's a marker of a process. So I'm mentioning this because I don't want biomarkers to be this, you know, big black box that's esoteric out there in Netherlands. It's just nothing. It's just what we use to mark the pressure. The exemplar for us TBI researchers is troponin. When I was a resident a million years ago, an old man like me came in with chest pain. You had no idea it was just a MI or pleurisy. There was some sort of EKG changes, but it was kind of blurry. Now we know you get troponin, yes or no, pretty clear cut. How about those head injuries? Well, there's somebody, an adult with a knife to the head, a gunshot wound again, a battered baby. And why do we need a biomarker for that? Surely we know the diagnosis, right? I mean, no ER doc is going to say, geez, that person with a knife sticking in them, maybe maybe the glucose is out of whack. Nobody does it. We all know there's no diagnostic dilemma. Can we all agree on that? So why do we need biomarkers? Well, that's where the problem starts. When do you do decompressive craniectomy? When do you give? What is the response to treatment? Individual susceptibility, blah, blah, blah. So you need to monitor response to treatment, safety, and prognostic, and in many different kinds. This is a slide that I borrowed from Track TBI, which we now fortunately have become part of, so I feel comfortable using it. These people had the same GCS, all 6 of them. They're different diseases. Surely we need to be a little bit more refined than that. You know, we speak about precision medicine. In TBI, it's imprecision medicine. 40 failed trials. It's ridiculous. Where we need to be is more like breast cancer, brain tumors, where when I was a resident, all women with breast cancers were more or less treated the same way. Then there's hormone markers, and became more and more stratified in individualized genetic markers, and that's where we need to go with TBI. And that is my quest. And you know, you just think about it for a nanosecond, TBI could guideline medical management. We still don't know, do we need to do early versus late decompressive craniectomies, let alone the whole controversy about decompressive craniectomies. Decisions whether it's quality of life, and of course in the less severe patients, concussion. So what is the ideal biomarker? Well, it's biologically stable, easily accessible, inexpensive, reflects ongoing physiology, in other words, a short half-life, rapidly measured and specific to the disease. Bottom line, it doesn't exist right now. Certainly a lot of efforts have been put into it in adults, my adult colleagues, less so much in pediatrics, and just a brief look at the literature will show at least 4 times as many papers in adults than pediatrics. That said, we still look at the same biomarkers in children, be it neuron-based, glial-based, from the myelin sheath, axon terminal, blood-brain barrier, or what we're particularly interested in, microglia or inflammatory markers. The one that we're particularly interested in is this glycoprotein called osteopontin, which we found in a stroke model was best representative of neuroinflammation. We took that information, we did a cortical controlled impact in mice. Sure enough, osteopontin was elevated depending on the degree. Having a translational lab, we did it in our subjects. We did a initial trial, pilot study. They're the nurses, my unit, modeling admission, 24, 48, 72-hour blood collections, kids aged to 18, and geez, sure enough, we found that osteopontin was also elevated in human subjects as well as mice. 2 good things happened out of that. First, we got a publication. Secondly, we got an NIH grant, and we have now collected and analyzing about 600 kids with this problem. These are the preliminary results. I'd ask you not to take any photographs, well, you're welcome to take it, but this is not publishable yet. Specifically, we do question the GFAP with our methodology, and we're going back to look at it again, but we felt comfortable with the other markers, especially osteopontin and S100, and this was published a couple of months ago, which showed that these were good markers. So where can we use them? And this is just an example. I was going to leave the slide out, the residents told me to leave it in and show you guys. This is the biomarker profile of 2 patients with a severe head injury. I think what you'd be particularly interested in is this inflammatory marker. We had kids that were way higher than normal for each category of head injury. Mild, but there's some outliers. Moderate outliers. Severe outliers. And it turned out, when we went to the medical records, these were the abuse kids. And so the thought is that there's a different pattern of inflammation in abuse kids, because probably by the time they come to me and you, this is not the first time that they've been abused. So what are the challenges? Well, less industry funding, FDA hurdles are higher. We are very limited amount of blood we can draw from the patients. Our hospital is very strict, less than 2 cc's per kilogram per hour. Of course, labs take precedence. Pediatric specific challenges are across the board, but especially in the rare diseases, where 90% had no treatment and nearly half of all trials go unfinished. In fact, if you look at the complexity, and that is our algorithm that I'm showing you there for our TBI study, it requires all those things, oversight, finance, personnel, logistics, blah, blah, blah. But across the board, Brewster published an article, how many studies got NIH funded? Got you 1 publication, less than half, 39%, and that's across the board for pediatrics. So a number of steps have been taken to keep them engaged, to increase your recruitment and retention. Frankly, our oncology colleagues are much better than we are. They are masters at recruiting all their patients. This is one quick example. A 6-week-old female was called down to the emergency room, multiple petechiae and bruising, intubated, IO access, and they expected abuse. She was bleeding rectally. It was just weird. rushed to the CT scan, and that's what we saw. And I said, well, that's significant, but doesn't look like abuse. And as we were in the CT scan, we get the white cell count back, greater than 400,000, and she had acute lymphoblastic leukemia. She was enrolled within 24 hours in the trial, which was quite impressive. Other problems for TBI-specific things is that there are no good clinical models at different ages. Indeed, the age groups are not quite well defined. There is a work group that's going to standardize the way we collect bios and store the biospecimens. And there are ethical challenges. You know, you go to a patient's mom and ask them to enroll in a trial, they think they're going to get better treatment, and you have to guard yourself to be sure that that is not the case and that they are giving consent and the child's assent appropriately, especially when using genetic material. How about cross-cultural studies, LMICs studies? Well, I can go on and on, but I think that article in the Journal of Ethics said it best. Ethical approval in developing countries is not optional, and absolutely every cultural aspect needs to be taken into account. If I could have one wish list, it would be that we have that graph, again, minute, days, months, and years, for the different biomarkers after TBI. Those are for adults. We don't know what it is for children. We don't know what the normal values are, and that needs to be found out. So what are those are all the negatives. What about the promises or the opportunities? Well, biomarkers are already being incorporated in guidelines, and there's a huge attempt to incorporate them more and more, especially in Scandinavian countries, not only including in resource-based guidelines. What about the technology? Point of care. That is becoming more and more prevalent. iStats to measure GFAP and other biomarkers would be fantastic. And then usually there's somebody who said, oh, but what about the cost and LMICs, and how can you know, what about the cost? Well, I threw this in. This is the cost of an iPad chip in the 1950s. I don't think any country could afford it. It was trillions of dollars, and it's now come down to $100 or so. So in conclusion, let me say that biomarker investigations includes diagnostic, therapeutic, and monitoring markers, as well as prognostic. They have the potential to greatly enhance TBI management in both high and low resource environments, but more robust multi-institutional studies are needed in children, of course, with safeguards while crossing cultural and economic barriers. Thank you so much.
Thank you. Great talk and a real tour de force of the topic. Any questions for Dr. Reisner?
Great, thank you.